Ladies and gentlemen, Mr. Chairman, I'm Francesco BURZOTTA from Rome, Italy. These are my conflicts of interest. I would like to start remembering the fact that bifurcation stenting techniques are a growing and confounding family. The first who wanted to push to fight against the confusion was Yves Louvard, and he was the leader of a consensus document in which the concept was to recognize that in bifurcation stenting you may start with a plan and end up with a different conformation of the stance. The final appearance was the creation of a MATS classification, which is based on the position of the first stent and also on the number of implanted stent following a dedicated sequence or not. Can we have now more than MATS? Well, after more than 10 years, some techniques have been abandoned. The value of ballooning technique like pot, kissing, side branch relations, and their sequence of application has been strongly recognized as important factor, and some dedicated devices became popular. So there was a strong reason to try to update the stenting classification, and the white paper came out on 2020 having the revision of the MATS classification with the MATS 2, which has been updated. There were key technical principles to guide the clinical practice inside. Indeed, crossover stenting, sized 1:1 according to distal main branch, followed by pot, has been recognized as the minimal treatment for any bifurcation. Kissing balloon inflation has been recognized mandatory only and for all two-stent techniques, and also regarded as an index of technical success, since the performance of final kissing is probably more important than two-stent technique selected. A family, T-tap and culotte, can be effectively considered to implant two stents anytime risk of side branch occlusion is not high. On the opposite, S with DK crash as the correct sequence, but also inverted A, inverted culotte, inverted T-tap, can be electively considered to implant two stents anytime risk of side branch occlusion is high and the operators decide since the beginning to implant two stents. So we have, we did a step forward in the understanding, but is this enough today? I think that when you have a situation like that, we didn't solve many doubts that the operators may have to use or not imaging, how to predilate, to use or not debulking, how to implant first stent and how to end up in this kind of patients. And this is why there is room for improvement and welcoming new technologies that may help our practice when we have complex questions. In this regard, artificial intelligence is coming out. The definition of artificial intelligence is the use of mathematical algorithms which give machines the ability to perform cognitive functions such as problem solving, object recognition, and decision making. So all of these aspects can be incorporated in the improvement of treatment of bifurcation PCI. For example, if we aim to describe bifurcation anatomy, we know that it's not easy task, and if you start from angio, we recognize the fact that there was a strong improvement in QCA bifurcation algorithm that are actually used in trials. However, the automatically detection of bifurcation lesion anatomy based on deep convolutional neural networks is a reality that has started to build. Also, invasive imaging may gain something from it. We know that if we have an image, we may take time to have appropriate analysis of the images. We may look forward to have a deep computational network for automatic OCT plaque characterization. And from this, we may expect that the time for analysis is strongly reduced. And we may also look forward to learn from images like that, processing that allows us to really understand the plaque anatomy that may also be helpful in procedure planning. Other aspect is the hope to simulate bifurcation stenting using patient-specific data. And I think that there are several groups represented at the EBC during these years that really worked hardly in this direction. And this is a recent review showing how it is now possible to reconstruct before and after PCI the anatomy, especially integrating angiographic analysis, 3D-dimensional reconstruction, and OCT imaging, so that we will know a lot from it. And on the basis of these images, computers may start simulating different techniques from patients' data. So identification of patient-specific optimal stenting strategy is what we ask for, but also reduced need for bench and animal research, stent design and mechanism and mechanics optimization and educational tool may come together. Other aspect is to predict events by processing big data. So we know that we may learn from the integration of imaging, clinical aspects like ECG, clinical presentations and labs, and all together might be processed to generate pre-procedural risk of adverse events stratification, integration with cognitive computing to support clinical decision-making by selection of management strategy, intraprocedural monitoring of multiple data, and personalized models of therapy like dual antiplatelet therapy length. So last aspect, probably, more easy to be captured, especially for educational aspect, is a better visualization of imaging. And I really am starting doing it with some companies, and we will see in the future much more. Thank you very much for your attention.